So relative sparsity for medical decision problems, and this will appear in Statistics in Medicine in 2023. So we have we'll introduce the framework and we'll discuss the behavioral policy or the standard of care. So we'll introduce what's called the behavioral policy, which is a major player in the work that we'll be discussing. So in particular, we're going to describe a patient with a k-dimensional vector, which we call the pre-treatment state. So the vector will be named S. This might contain, for example, the patient's initial heart rate and the patient's initial blood pressure. The pre-treatment state is sampled from some distribution on the pre-treatment state. Given the pre-treatment state or the characteristics of the patient, we may then decide to take some treatment. So a treatment might be a binary action, for example. And it might be, for example, whether to take vasopressors, which can be a yes-no decision for hypotension. So vasopressors are medications that increase blood pressure in the setting of dangerously low blood pressure, which is called hypotension, which sometimes occurs when patients are bleeding, for example, or have bloodborne infections. The reduction to a yes-no decision is somewhat of a simplification because vasopressors can be given in different doses, for example. We're going to sample the treatment decision based on the characteristics, the pre-treatment characteristics of the patient, S naught. And generally, this conditional distribution of actions given states is denoted as pi. It's given a special symbol pi, and it's called a policy because it's a mapping that informs actions given what we know. So, for example, one might draw the vasopressor action with probability 0.3. So the probability that A naught, the vasopressor, is equal to 1, given the patient characteristics, is equal to 0.3. We're going to subscript the policy as pi naught to indicate the data generating behavioral policy or the standard of care. So you imagine if we sample a pre-treatment state and then we sample an action conditionally on the state, if we look at the data that's truly sampled in the clinical workflow, it's that action given the state is sampled from the behavioral policy or the standard of care. That's what informs the decisions that are made that then generate data that we then observe, for example, an electronic health record. Note that pi naught, the behavioral policy or the standard of care, is also known as a propensity score. Given the action, so given the pre-treatment state and then the action that was sampled, we'll obtain a post-treatment state, which is another vector that describes the patient. So for example, it might be their final heart rate and their final blood pressure. This final state, the post-treatment state, is sampled conditionally on the pre-treatment state and the action that was taken. These two things influence the post-treatment state. The final blood pressure is influenced by the action that was taken, whether vasopressors were taken, and the initial blood pressure, for example. Putting this distribution, or really the behavioral policy distribution, and the initial state distribution together, we obtain a sampling distribution. And here we're just making it clear that it depends on the behavioral policy or the standard of care to draw actions. So we've talked about the policy that generates the data. We might also want to think about a policy that maximizes some reward function. So what is a reward function? So it's a function on the states and actions. So concretely, an example might be that we'll take the final state, the post-treatment state, and the second covariate, which is the final blood pressure. So if a patient has low blood pressure, one might want to increase this reward to make them have higher blood pressure. Often, in the outpatient setting, we might want to reduce people's blood pressure, but in an inpatient setting, sometimes if they're, for example, bleeding or something, we might want to increase their blood pressure. Recall that pi naught is the behavioral policy, the data generating policy, but pi is an arbitrary policy. Now we're going to write the expected reward in terms of an arbitrary policy, and this is called value. One can define the value, it's denoted V for value, or the expected reward as V naught of pi, which is the expectation under pi of the reward. And this subscript by pi is just to indicate the expectation is taken with respect to the policy pi. And we're just writing out the expectation here to show how it depends on the policy pi. Indeed, we see the sampling distribution here, and we see that the policy pi appears here. The naught in the V naught indicates an estimand. Note that the naught in the one in the states and actions sort of index time, but the naught in the V naught indicates that V naught is the true reward or an estimand, which we might be estimating in the future. Given this function for the expected reward or the value of a policy, one can obtain the value maximizing policy by finding the policy that maximizes value. And this we'll, for example, call pi star. This might be the policy that maximizes the final blood pressure of the patient. This is known as policy search in especially the computer science literature. Note that this framework here of taking expected reward and looking for the strategy that maximizes the expected reward is really based on expected utility theory, which has been studied for hundreds of years actually. So some more recent work in computer science considers more sometimes complex sequential decisions. But this idea of expected reward and finding a treatment strategy, for example, or an action strategy that maximizes expected reward has a very long, rich history. So we can build on some very strong work in our application of this to medicine. So we've discussed how we can find a policy that maximizes the reward, and we've discussed how we can find there is a behavioral policy that generates the data. One may choose, to interpolate between these two policies to get something in the middle between these two policies. This is known as behavior constrained reinforcement learning. It was referred to this in one paper on this topic, and it's kind of a good descriptor. So we're essentially constrained to stay close to behavior. So there are many researchers have worked on this. These are just some papers that influenced us, especially Futoma, Uno, and some papers that approach it from very different directions, different fields. So computer science, statistics, kind of biostatistics, computer science. We're going to especially focus on the behavior constraint formulation from the robotics field. And we'll focus in particular on one technique called trust region policy optimization, TRPO. And this was developed by Schulman in 2015. There have been many extensions of this, but if you write trust region policy optimization just with a Lagrangian term, this is the objective function that emerges. Here, they're maximizing expected reward, but they're adding a KL divergence, Kullback-Leibler divergence term, and they're constrained to some old pi-old policy where pi-old is known. So the goal here is to increase the average reward or the value, but stay close to some old known behavior. In particular, in the robotic setting, this old behavior is often what the machine was doing maybe a few minutes ago, because that's known that was programmed in the machine before. So why might one do this? Why might one constrain to behavior in general? So one reason is that it stabilizes optimizations, which can become very complex in the robotic setting. So if we're climbing some kind of objective function, you can imagine that and this was kind of an analogy given by this actually a blog post by Huey in 2018. So you can imagine that if we're climbing some objective function, it's like climbing a mountain, And if you take too large of a step, you may fall off the path that leads you to the top. And so this scale divergence term constrains the step size, and that then constrains the optimization itself. More recently, it's also been discussed that the scale divergence penalty that constrains to old behavior can be used for safety. For example, one may not want a machine to change its behavior too drastically from one moment to the next. We're going to play on this. We are going to now consider how this type of objective can be useful in a medical setting. And so we're going to be thinking about things like safety, and we're going to now try to think about what we need in the medical setting as opposed to the robotic setting. So our goals, we're going to now define our goals. So we think that certain properties of a policy facilitate translation to clinic. So that's kind of our epistemological basis for this work. We're thinking about how to get a new treatment strategy that will be used in the clinic. There's been a great amount of work on developing treatment strategies with sophisticated statistical modeling techniques. For example, in the dynamic treatment regimes literature and in the reinforcement learning literature. But these techniques, these new treatment strategies, are difficult to translate to the clinic. They're not used often in the clinic. Decision models are not used in the clinic. So we're trying to think of what it is about a policy that will make it facilitate its translation from the research bench to the patient bedside. So we suspect that two properties aid with this. So the first property is that the policy, the new treatment strategy, be closeness to the behavioral policy or to the standard of care. So we define this as the policies roughly agreeing on the probability of treatment. So we think that this facilitates adoption because if one tells a healthcare provider to prescribe, for example, with probability 0.99, but the healthcare provider's intuition is to prescribe with probability 0.01, or the standard of care is to prescribe with probability 0.01, the recommendation of the model likely will not be adopted. Having the policies agree on probability of treatment also reduces the risk of drastic changes. So this is similar to the safety idea in robotics. A drastic change to clinical practice can potentially cause harm. So if we are conservative in our movement from the existing standard of care, we reduce the risk of this occurring. Note that this is achieved by the trust region policy optimization developed by Shulman and al., which was on the last slide. This closeness is achieved. So we're going to want to keep this closeness. One thing, however, that's unique to the medical setting is that one must justify the policy to the healthcare provider. One must justify a change in policies to the healthcare provider. So to this end, we want a new policy to have succinct, interpretable differences from the behavioral policy or the standard of care. So this will make it extremely transparent how things are changing, how we are changing the standard of care in our new policy. And this aids with justifying the policy. The onus is really on the analyst to justify a change to a new policy. This is the motivation for what we call relative sparsity. So just to recap, so we have some behavioral policy, and they are generating the data. This is how the care is administered at baseline. They are maximizing some behavioral reward, which is likely sensible. We can specify a reward. For example, we might specify the reward as the final blood pressure in the setting of hypotension. And one can optimize the specified reward and obtain an optimal policy in quotes, because it's really the reward maximizing policy. So it depends very much on the specified reward. So in our case, for example, just maximizing the final blood pressure would actually not be, would not result in the best policy, because vasopressors have side effects. So to optimize the final blood pressure, one would always prescribe vasopressors, but vasopressors have side effects. So in our work, we interpolate between this reward maximizing policy here and the behavioral policy, which maximizes the behavioral reward, to obtain some suggested policy, which is in between the two, and which maximizes some interpolated reward. And our hope is that this suggested policy will be closer to the truly optimal policy and the true reward than either the policy that maximizes the specified reward or the behavioral policy. So we can nudge in certain directions. We can say that we want to increase the final blood pressure, but we don't commit fully to a specified reward that might be overly simplistic and that might take us further from the true reward than the behavioral policy was already. So this is the idea behind closeness to behavior. Now, in terms of interpretability, which is again something that's really unique to the medical setting, we want it to be very, very transparent how the suggested policy differs from the standard of care for the behavioral policy, and that is the idea behind relative sparsity. So recall that V0 is value or expected reward. So if a policy has good value, it has good expected reward. It's like the value, the worth of the policy in a sense. If you increase the expected reward or final blood pressure, you'll have good worth of the policy, you'll have bad value otherwise. And that trust region policy optimization, again by Schulman et al. From the robotics community, is this mixture of expected reward or value and a pull towards the old behavior. So how are we going to change this to achieve the goals that we've set out? So in particular, we're going to choose an interpretable, identifiable parameter for the suggested policy. So note, in this objective function, the policy is arbitrary. So there's no reason that the policy should have parameters. It could be something completely it's really difficult to imagine in the sense of parameters, like some kind of random forest or something, or it could have parameters, but they may not be identifiable. And identifiable means that one can estimate the parameter uniquely and kind of understand the parameter. So for example, like a neural network might have parameters, but the parameters won't be identifiable. There will be many different solutions to the same problem. So that makes sense in these types, in the robotics setting, where often the data of interest are pixels or text, and so the individual features are difficult to actually analyze. But in our case, we want to know exactly how the state covariates are affecting the action that's taken. So we're going to make sure that the parameter, the weights on the state covariates, are what we call identifiable. We can solve for them uniquely and we can understand them. So we're going to choose an interpretable, identifiable parameter for the suggested policy. So in particular, we're going to make the probability of taking an action 1 given a state, as an x-bit function, which has a linear combination of the state covariates with some parameter that we can then identify. And this is just the definition of the x-bit function. It's a logistic regression. So we are imposing some structure on this problem, and because of this, we might obtain a policy that can't maximize value fully because it's somewhat constricted, but we will, it's a trade-off between this constriction and being able to understand how the particular state covariates are affecting the action decision. So we define the policy in this way, and then we sample the action itself from a Bernoulli distribution, which is parameterized by pi beta. We're going to assume the same model for the behavioral policy. So pi naught, the data generating policy, will become pi of b naught, where b naught is some finite dimensional parameter. So this is more of an assumption. The first point is really more, this point is really more of a requirement. This point is more of an assumption, and this could potentially be relaxed in future work. But the idea, the idea is that we have to somehow represent the standard of care, and how one chooses to represent the standard of care might be more flexible, and indeed how one chooses to represent this policy might be more flexible than what we describe here. But that would take some extra work to develop. So we're going to assume that the behavioral policy too has this form, but it's parameterized by B naught. So these parametric forms set the stage for what we call relative sparsity. So we are also increasing expected reward, but we are imposing an L1 norm penalty on the difference between the parameter of the policy we're optimizing over and the policy of the parameter of the behavioral policy. So if you can define, however you choose to represent these two parameters, if you can define some kind of sparsity on them, in theory, this method applies. So for example, if you were to represent it with basis expansions, if you were to use basis expansions here of the state rather than the raw state, and use basis expansions of the behavioral policy, you could obtain some kind of sparsity here. The interpretation would be diminished in that case, but it's still kind of a valid idea of some kind of relative sparsity between the two models. Note that the objective here from the robotics community and the objective here that we're using that's tailored to the medical setting have large differences in motivation. So there's not many keystrokes to go from this to this penalty and to kind of parameterize the policy, but it leads to, it's very tailored. This bottom objective is very tailored to the medical setting, whereas the top objective is very tailored to other types of settings. So just a few notes on shrinkage caused by the L1 penalty and a few notes on fusion penalties more directly and how they relate to what we're doing here. So recall that this is our objective function to maximize expected reward and stay close to some behavioral policy. Note that the L1 penalty here, which is the lasso, both selects and shrinks coefficients. So generally the shrinkage of the lasso is considered a drawback because it biases the estimates of the parameters. But in our case, actually, shrinkage is important for closeness to behavior. So if one only maximizes expected reward and doesn't have a penalty term here, the parameter under the model that we've required, the expert model, that maximize the expected reward will diverge in magnitude. At least one entry of the parameter will diverge in magnitude. This is so that the expert function essentially can, when the expert function needs to approximate an indicator function, this occurs. And the indicator function is the optimal policy. That's just been something that's shown in the literature. So if this parameter diverges in magnitude, if beta is diverging in magnitude, it will become far from the behavioral policy, and that will become far from the parameter of the behavioral policy, and that will lead to a large distance in the recommendations given by the suggested policy and the behavioral policy. So the shrinkage in our case of beta to B naught is important to give us closeness to behavior, which is something that we want to keep, that that was in trust region policy optimization, and we want to keep here and is important for facilitating adoption of new policy. Note also that relative sparsity is different from a fusion. In a sense, it's simpler than a fusion. It's kind of a recentering of a lasso. So just to show this in a picture, so this is the typical lasso diamond that one sees when we're looking for absolute sparsity, when there's no beta naught, B naught is essentially 0 here. We're just recentering this diamond around the parameters of the behavioral policy. And that then gives us a suggested policy parameter that has favorable properties in terms of the policy it indexes for the decision problem. So it's very closely related to why we would do this is very closely related to the decision problem. And note that we are fusing beta to B here. So there is a fusion occurring there, but we're not fusing B to beta. So in a typical fusion, both of the parameters would be jointly fused together. But here we're just recentering. We're not doing a joint fusion like that. In fact, we have to be very careful about how we estimate the policy, the parameter of the behavioral policy, for reasons that we'll now describe. In particular, we need that the behavioral policy be correctly specified. So this is related to estimation. So estimation in this problem is particularly difficult. The difficulty arises because the behavioral policy generates the data that we observe. So if we observe data from an electronic health record, it's observed by the standard of care, by providers who are acting according to the standard of care. But we want to know the expected reward or the value for some arbitrary policy. So you need to be able to evaluate this with respect to some arbitrary policy if you want to search over policies to find the policy that maximizes it. So one can write the value. So it's the expected reward under the value of a parameter, the index, an arbitrary parameter, the index is a policy, is the expected reward under the policy parameterized by that parameter. And one can multiply this reward here by pi b naught over pi b naught. And then if one rearranges, we then obtain an expectation of this reward that's multiplied by this ratio, but the expectation becomes in terms of the data that we observe. So we can then estimate the value for an arbitrary policy given data observed from a different policy. So this is a well-known technique here. It's a very interesting, this idea of estimating counterfactuals is very well known and very well studied. And so we'll give some references, but essentially, we can define, it's very kind of magical what's happening here, essentially. And a lot of people have realized this in different fields. So we'll define a plug-in estimator for this value as Vn. So n here is denoting an estimator. So we're going to just make this outer expectation empirical, and we're plugging in then for the behavioral policy as well. And again, the subscript n is knowing an estimator. So we can estimate this from the observed data. We observe everything in this expression. This is known as inverse probability weighting or importance sampling, and it has actually other names, and it's been studied extensively in the causal inference literature, the econometrics literature, the offline reinforcement literature, statistical Monte Carlo literature, for example. Here we in a sense are identifying this quantity in terms of quantities that, distributions that we can estimate based on the observed data. But there are ways to formulate this in a causal framework, and we will just mention the causal assumptions that are at play here. Causal inference is very explicit about what assumptions are necessary to do something to make this kind of estimation. So no interference and consistency are common causal assumptions. They're useful for identification. However, we'll focus on the bolded assumptions, which can give us more trouble sometimes. So in particular, there's positivity, or that given any state, any patient characteristics, there must be some probability in the standard of care of giving either action. It doesn't have to be a high probability for either one, but it must be possible. So you essentially need you need to observe enough variation in the treatments that are prescribed in the data for a given patient to estimate something like this counterfactual. If you don't observe that variation, you can run into trouble. And also, if you're dividing, this is essentially, if this is ever zero, you could end up dividing by zero, which could be problematic. One also needs the correct specification of the behavioral policy. So note that the behavioral policy here is dividing this expectation. So one needs that this behavioral policy is correctly specified. If it's not correctly specified, this division essentially won't occur correctly. And this is important for we make kind of a strong assumption. We assume the behavioral policy is an expert model, which is a restricted model with a finite dimensional parameter. So this is a assumption that is strong in our work and could potentially be relaxed. We also need that there is no unmeasured confounding. So we need that any state So the state here, which is used by the behavioral policy to make a decision, needs to contain all the information that affects the action, and it also affects the reward function, where the reward depends on the final state, for example. And so the initial state affects the final state. So this is called the no unmeasured confounder assumption. And it's very important to talk with healthcare providers about what they are using to make the treatment decision in order to satisfy this. And it's an unverifiable assumption, but one can make progress in the direction of feeling more comfortable with it in close collaboration with the healthcare provider. However, it is really a major difficulty in the field of using observational data to estimate these kind of counterfactuals. The no unmeasured confounding assumption is a major Achilles heel, and we inherit that Achilles heel in our work. If we accept these causal assumptions, we obtain a plug-in coefficient estimator that we are plugging in for the value of this estimator here under under all of these assumptions, just to drive this home. In other words, if the healthcare provider is considering some variable like serum creatinine, and you don't have it in your covariates you've measured, you can't use this kind of estimator. Also, if the final outcome depends on some covariate heart rate and you don't have it in the covariates that you're considering in S, you can't use this estimator. So you need everything that affects the action and the final state. So I'm just drive this home. Okay, so if you accept these assumptions and you've been careful about what to include in the final state, then you obtain a plug-in coefficient estimator where we are using the value estimator before, and we're plugging in for the behavioral policy parameter and the penalty. We are going to give also a proposal to select lambda, the tuning parameter, or the weight on the penalty based on both value and the number of selected coefficients. So this is going to give us a way to, we won't just estimate the policy parameters, we'll also give a policy itself. When you select lambda, you end up getting one value of beta n lambda, and then that will give a policy, and then you index a policy by this, and that will give you a policy itself. So we'll show now in simulation. So recall that we are taking a combination of expected value and also the penalty. We're going to let R be in our simulations the final state, the post-treatment state second covariate, and we'll make it depend most strongly on the initial state second covariate. So for example, final blood pressure depends most strongly on initial blood pressure. So we're showing here a diagram that's modeled after the lasso diagram, where we have in the classic lasso diagram, lambda increases on the x-axis and the coefficients are on the y-axis, and all of the coefficients go to 0 as lambda increases. In our case, we'll have the dashed lines are going to be the parameters of the suggested policy, and the horizontal lines, solid lines, will be the parameter of the behavioral policy. So you see we're pushing the dashed lines to their behavioral counterparts as lambda increases. It's pushing in this penalty that way. Note that some of the coefficients hold out against this push. Some succumb quickly to this push. In particular, one holds out strongly. And that is the one that's relevant to the reward, to maximize the expected value here. So it's S0 which is most important for the reward. So as we increase lambda, we decrease the value concomitantly, and but we can obtain some value. So when everything's fixed to its behavioral parameter, when all the suggested parameters are fixed to their behavioral parameter, we obtain the value here, but we can obtain value that's above that value, but we only have to change one of the coefficients. So we've actually automated this lambda selection procedure, and we show a histogram of the lambda selections over data sets. This diagram is kind of a summary of Monte Carlo data sets. So now we'll show the individual Monte Carlo data sets and the properties of the estimator that we derive. In particular, again, this is the objective function. So we are going to be looking at the unconstrained policy, only maximizing VN, the suggested policy, maximizing the mixture or the proposed method, and the behavioral policy, which generates the data. So the unconstrained policy has the most value. We're maximizing value. The suggested policy has less value than the unconstrained policy, but it has more value than the behavioral policy, which generates the data, which is independent of this value, or not solely trying to maximize this value. We also observe the probability of treatment over data sets. So when one only maximizes value, the best thing to do, the way that we've set up the simulation, the treatment has a positive effect on the change in the blood pressure of S02 going to S01. So the best strategy is to always treat. In our case, we don't do that. In the suggested policy, we pull towards the behavioral policy, which has a probability of treating usually of about 0.6. So this is closeness to behavior, one of our goals. We also observe the relative sparsity from each of the policies. So in particular, we have the number of coefficients that differ from behavior here. And you see that in the unconstrained policy, because there's no penalty here, all of the coefficients differ from behavior. In the suggested method, when we have this penalty, on average, just one coefficient differs from behavior. So we only have to make a small change to one coefficient to get an increase in value that's somewhat substantial over the behavioral policy. And finally, in the behavioral policy, no coefficients differ from behavior. So we obtain relative sparsity. Closeness to behavior, relative sparsity. So now that we've shown our simulations, we will proceed to a real data analysis. We want to note that especially because of some of the causal assumptions some of the assumptions related to observational data that we've discussed before, application of the proposed method is still a research topic. Indeed, developing treatment strategies like this from observational data is still a research topic. However, given all of the observational data that's collected in routine clinical settings, this is a very, very, very good research topic to support. So these kinds of models that can help operationalize these kinds of observational data sets to helping make decisions that improve outcomes is a very interesting and potentially impactful research topic. However, we're not offering in this application, we'll be analyzing real data, but we're not offering medical advice, for example, based on this application. It's really to illustrate the proposed method and it's doing what it should be doing. Remember, the proposed method is applicable to any kind of medical decision problem. And so we're not necessarily focusing on doing new work in the application. We're not necessarily writing an application paper here where we're going to make firm conclusions about how care practices should change. We're not doing that. So we're just illustrating the proposed method, and we're illustrating on the Mimic4 critical care database. And this is a well-known electronic health record critical care database. In particular, we're going to consider a one-stage decision in the medical intensive care unit. So in other words, we're going to just consider baseline blood pressure, what action to take, and final blood pressure. We're going to consider the management of hypotension, in particular during the initial 30 minutes. The action will be vasopressors. Note this is a simplification because vasopressors can be given at different doses at different rates. But we're just going to consider whether the vasopressor is given, yes or no. And the reward will be the final blood pressure. Again, this is an imperfect reward. Vasopressors have side effects. It's not beneficial to maximize the final blood pressure, but it is sensible to try to increase the patient's on average final blood pressure ultimately. blood pressure is important for maintaining perfusion. Note that we're not taking into consideration things like urine output and or side effects in this reward. So it's a simplified reward, and that's part of the reason we have this caveat on the conclusions that we'll come to here. That said, we worked very hard on this data analysis, and it was extremely intensive to obtain the results that we do. So recall that this is the objective function. We're maximizing both value and we're pushing towards behavior. This is the same diagram that was inspired by, that was modeled after the lasso diagrams. Here we're increasing lambda along the x-axis, and along the y-axis we're showing the dashed suggested policy coefficients and the behavioral policy coefficients, which are solid. You see that we have real covariates here now, mean arterial pressure, heart rate, for example, and the coefficients, most coefficients quickly are pushed to their behavioral counterparts. They're not as relevant to the reward, but one coefficient holds out. In particular, that coefficient is the mean arterial pressure. So like in the simulations where initial blood pressure impacted final blood pressure, initial mean arterial pressure here is impacting final mean arterial pressure, which is the reward. So we can obtain a policy here that so this actually we are obtaining some value that's above some threshold that we've kind of pre-specified above the behavioral policy, but we only have to change the coefficient of one of the covariates, and in particular here we're kind of attenuating the coefficient on mean arterial pressure. So we show here just the lambda selections. We're resampling this data now to obtain the distribution of the lambda selections. So we're going to look at the resampled, the same diagram that we saw in the simulations for the resampled versions of the real data analysis. So we are going to look at the suggested policy again, the behavioral policy. So you see that in the suggested policy, because we've defined this reward, the final blood pressure we want to maximize, and that's in our objective function, we're maximizing this more than in the behavioral policy. And in truth, the behavioral, the true healthcare providers are not so focused solely on maximizing this. So we're pulling towards maximizing this more than they do, but we may even be pulling a little bit too much. Maybe it would be better to have something around like 58. They're around 57. Maybe it would be better to pull towards like 58. And one can do this by just the choice of lambda here. But we see here essentially that we can get a value. We're maximizing more the specified, we're increasing the specified reward relative to behavioral policy. When we do this, however, we're not necessarily, one way to do this is to always give the patient a vasopressor, but we're not doing that. So we are more discerning. We're pulling towards the behavioral policy, which has a relatively conservative probability of treatment usually. One could, of course, again, by increasing lambda, one could pull closer to behavioral policy, and one would lose value if one did that. But it might be beneficial in this case to have a 1 unit increase in blood pressure, for example. Maybe a 3 unit increase is too much, and then we could get more closeness to behavior. We do obtain relative sparsity, so the mean arterial pressure coefficient is really the one that's singled out each time. So that is the final data analysis for the relative sparsity project.